Good afternoon, everyone. My name is Michael Webb. I am the Program Manager of Youth and School Communities here at Pima County Health Department. And on behalf of all of us here, we want to thank you for taking your time to be with us here today. We are going to be discussing measles in Pima County and pertinent topics related to your work in schools. And so just at the top here, we want to thank you for your commitment to ensuring the safety and health of students and their families. For those who are just joining us, you can add your name, your position and school district in the chat just to introduce yourself. A couple of ground rules for today. So we are recording and transcribing this meeting. We understand that health professionals are some of the busiest workers in our school communities. And so that means that not everyone can be here with us today. In order to distribute this recording, we want to ensure two things. So first and foremost, we need to make sure that no students appear on camera. So if you are in a space where students are present, I encourage you to keep your camera off. Just to play it safe. And then the second thing is when you are not asking a question at the end here, we'll give a designated time for Q&A. Please remain muted. And then I'm adding a third thing here is in terms of your audio, if you are unmuted, please be sure not to discuss any private medical information regarding a student on this call. Again, that is all in an effort so that we can ensure that we can disseminate this recording. Allowing video and audio allows us to be interactive, but if we work together, we will be able to distribute that recording. All right, without any further delay, we want to make the most of your time today. So today's presenters will be myself. I will be the Master of Ceremonies guiding us through. And then we have two subject matter experts, one from our Epidemiology Division, Anissa Taylor, and Laura Larson, Registered Nurse Manager in our Clinical Services Division. Before we begin, we like to start with a land acknowledgement. On behalf of Pima County residents, we honor the tribal nations who have served as caretakers of this land from time immemorial and respectfully acknowledge the ancestral homelands of the Tohono O'odham Nation and the multi-millennial presence of the Pasquayaqui tribe within Pima County. Consistent with Pima County's commitment to diversity and inclusion, we strive toward building equal partner relationships with Arizona's tribal nations. At this time, I'd like to introduce Anissa Taylor from our Epidemiology Division to take us through the first slides. Anissa?
Hello, thank you. So currently what we know in Pima County, I'm sure many of you have heard from our press releases, we have had recent measles cases here in Pima County. We did have a case in December. That was an unrelated case. There were no community exposures in that case. January 2026, we had two cases. With those cases, those are both adult cases, so not children. They were what we consider epidemiologically linked cases. So with that, our team does contact tracing. We are still under surveillance for those contact tracing cases. Currently, the first of those two cases, so technically the second case, the contact tracing will end this week. However, we're considering enhanced surveillance. We go out 2 incubation periods. So as you know from schools, we do this without breaks when we work with you all. We will count 42 days is what we do. So instead of the 21. So we'll continue to do that for the second exposure out until February 11th. We're working with the state to look up MMR records when in ACEs. So thank you again for making sure to check your children that are entered in there, all your students. ADHS is assisting across the state, as you know. Currently, there are 34 current cases of measles across the state. They are very busy, so they're assisting us in Pima County as well as all the other states. So this is important because if a child is not just exposed here in Pima County, if they're traveling interstate, you know, there's lots of competitions with sports. Just be mindful of that. For instance, last year, just ending 2025, there were a total of 220 cases in Arizona. So again, we need to be mindful that we're having measles across the state here. Next slide, please. And I added this slide in here. This is national data. And the only reason I added it is because I wanted to highlight some things that are important about immunization. So if you look in the age groups here, the big piece from last year in our large measles outbreak across the United States is 5 to 19-year-olds, and that's going to be our majority in the school setting, right? I know a lot of your schools have preschools attached and childcare centers attached, which is another big age group of the affected in our large measles outbreak. But if you're looking at the large numbers of 5 to 19-year-olds, those are going to be the large groups that are going to be unvaccinated or unknown. They're going to be most affected. So just please keep that in mind with your parents and, really explaining how important the MMR vaccine is, because when we're doing these contact tracing and case investigations and opening up our clinics, that's who we're really trying to target right now, is your population. Next slide, please. And I'm going to go ahead and pass this on to Laura. Thank you.
Hi there, thank you. I'm Laura, the Immunization Program Manager here at Pima County. We just kind of wanted to talk about the vaccination requirements for schools. They are at this time remaining the same. So for school-age children, it will be 2 doses, typically around 12 to 15 months and 4 to 6 years. Is for the second dose. However, sometimes people get them early or than the 4 to 6 year, and that still counts as your 2 doses. If 1 dose was given before the age of 12 months, then another dose will be required to hit that 2 dose. Right now, there has been some changes from the CDC on their recommendations, but the MMR has not been changed. So that continues to be the recommendation across the board. And next slide, please. We have 3 clinics that families can come to get their MMR vaccinations, and we have openings every day of the week, at least 1 clinic. We also have a Saturday clinic every month, which we post on social media, the dates for those. All insurances are welcome. However, insurance is not necessary. We will vaccinate everybody. We want everyone to be vaccinated and cared for, and money should never be a barrier. And that is pretty much it for me at this point.
So what to do if you suspect an infection in one of your students? Ideally, you should have a plan. That should be something that you're working with your district or your health office. It should be a pre-designated isolation area. A lot of schools obviously are not going to have a negative pressure room. We understand that. So if you can have a pre-designated isolation area, even if it's an outside area, a lot of schools developed this during COVID. So if you want to pull out your old COVID plans, that's a good idea to modify them for something like measles. Again, also something like I worked in the TB clinic and we worked with schools in that situation as well. So if you have that, make sure you have an area for observation for those students while they're waiting for their parent or guardian for pickup. And then if you can start working with your health office, I know it's hard depending on the resources and level of staff at your school, but where have they been in the school? If they just came in from outside versus, this is at the end of the day and they've been all over campus, it's going to be a little bit more difficult. But some schools I know are sectioned off versus, kind of a larger open campus. But if we can identify certain classrooms, cafeterias, libraries, things like that, it's a little bit more helpful because then we can determine who's exposed versus who isn't. And then, of course, the number one thing is what is the immunization status of the child, because that's really going to help us determine the level of risk. That's what we do in epidemiology, is we determine how likely is a risk? As you know, coverage for 2 MMRs is about 97% effective. That 3%, obviously, if there's some immune compromised condition or if the MMR was given, too soon during an exposure, there might be some breakthrough there. But again, if we can put that on the differential, then the risk goes down a little bit, right? So we really want to know the MMR status. And then, of course, if we can close off the areas as much as possible, if it is something like one area, for 2 hours after that suspected student has left and clean and disinfect the classroom, that would be preferred. Ideally, that's ideal. We know that that can't always happen if it's the entire school or large parts of the classroom or something like that. But that is the most ideal situation because that's what we recommend in the healthcare status or the healthcare settings. Now, if we can't do that, we do want to know of the other students who might have been exposed, what is their MMR status of those classmates? We want those exempt students and those students who are under-immunized to be noted. So we may not know if the student has measles or not. This is just a suspect, right? But we can do the groundwork first. So if we have an idea of, okay, we have maybe some students that are exempt because of health reasons, or they're newer students and they haven't got their documentation in yet, or we have some other students who may just be exempt for, personal reasons or religious reasons. If we have that already set aside and we can kind of get ready to ramp things up, then we know ahead of time. It's just better to be prepared than not prepared. So we'll always kind of ask those questions when it's reported to epidemiology. And then, of course, risk status as well. So again, like I mentioned, high-risk students who are immune compromised, maybe on dialysis or, chemotherapy, things like that. Same with teachers and TAs, any kind of volunteers. Pregnant, so they might need to tell their OBGYN. We just want to have a line list generated of exposed people just in case. It's better to generate that early than after the fact, just in case we need to coordinate prophylaxis. And that's what my team would be doing, is helping to work with our clinical team to coordinate that with the schools. And then, of course, number one is please report to us. So that number there is going to be 24 hours, holidays, weekends. We can help provide further guidance to you all. We also have notification letters, but we do want to wait for a lab confirmation, and we'll go further from there when that's the case. If they need to be in Spanish or other languages, we can work with you as well. So if you have questions on that, let us know. But we're always willing to work with you if you have questions or you're not sure. Next slide, please. Now, what should the parent do? So, of course, we don't want the parent to take their child to school, right? Or to anywhere in public, because there have been times when we've been working cases and we say, don't take your child to school, but then they take their child to a birthday party or to the grocery store. We don't want that. So we want to make sure that not only are we telling the child that the healthcare provider is telling the child that, and the parents that, but that the school is also telling the parents that, to keep the child home and isolated. We want the parents to call the school and to notify them that the child is out sick. And we want the parents to call their pediatrician or their healthcare provider and notify them of the symptoms. If they don't have a regular doctor, we ask that they call ahead to the pediatric emergency room. And when measles is suspected, EDs are preferred over an urgent care for an accurate evaluation and coordinated testing at our state lab. I understand that a lot of times urgent cares are used sometimes, and then we can work from there if we need to, but just with testing and coordination, it's a little bit easier with the emergency rooms because they have the proper resources to help facilitate the lab testing, and we can work with them that way. We want to ensure that the parents and the child are both wearing masks at the visit and practice good hand hygiene. So, what we tell the healthcare providers on their side is that we want people to come in through, a side door or have a later appointment so we're not exposing other people. So everyone has a role in this. We would like for the vaccine records to be available if possible. again, knowing that MMR dose is really important. We would like a list of everywhere they've been if possible. I know it's hard sometimes to kind of trace backwards where people have been, but it's really helpful when we're doing contact tracing. As we know, measles is very contagious because, again, 2 hours after somebody leaves, that airspace is still potentially contagious with the measles virus. We would like their child again to be home and isolated away from everyone until we're cleared by the health department. A disease investigator will call and we'll ask more questions. So we want them to know that we're going to be contacting them regularly. We're going to be checking in on them, and we're going to do that for the end of the incubation period. And of course, we can provide a letter for work for a parent or guardian if needed. And we've done that before. So next slide, please. Okay, I guess I'm done here. So any questions?
All right, we did have one question in the chat that I said I would come back to. That question is, so this is from Raymond Parkman. Like COVID, can we place the suspected case in the open air away from the school as long as supervision and weather permits? Would Epi or clinical like to take this question?
I could take this question unless Dr. Saul would like to.
I defer to Anissa.
Okay. So, I mean, ideally, obviously, is a negative air pressure room. And Dr. Saul, you can correct me if you like, but with the same that I learned with TB is open air away from everyone else is ideal. When we would have to transport people, we'd roll the windows down and wear a mask. So if you have a N95 and the person is being supervised by someone who we know their immunization status, then and there's no one else around, it's safer than exposing other people. So I would say that is safe.
Right. So keep your child safe. That is always rule number one. And number two, of course, if you can have eyes on them, great, while you're waiting for the parent to come. If it has to be indoors, please add a mask and open the window. We realize a lot of the facilities are older and it's not easy, but we do want to thank our school nurses. We can't fix your salary, but we can say thank you. We know that you do a great job advocating for immunizations and safety in families, and we do appreciate you. So whether your building's old or new, please do the best you can. Air shed is kind of the concept. Outdoors if you have to, indoors with a window open and a mask, do the best you can. Back to you, Michael.
Great, thank you. All right, next question I see is from Helena Brown. Do adults that have only had one immunization prior to 1980 need to get a second?
Are you trying to set me up? I'll take this one. Thank you. Excellent question. Around 1990 is when we began the strategy of giving most people 2 doses. So if you were born between 1957 and about 1990, you probably only had 1 dose. Now, for healthcare workers, we definitely chase them to the ground and say, yes, 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 get a second dose. But when you talk about people who are on the front lines of every infectious disease that moves through the community, that is going to be our teachers. And yes, as a physician, I recommend if you are working in daycare or in childcare or in schools, please talk to your favorite local provider about getting a second MMR dose if you have not already had one. 1 dose gives you about 95% protection. 2 doses raises that up to about 98, 99. So please consider getting a second one if you're born between 1957 and about 1990, 1992.
Great, thank you, Dr. Saul. Next question we have is, do adults or kids need IDs to get vaccinated?
Laura.
Actually, no, they do not. We do need a name and date of birth, and we do obviously prefer ID, but that is not necessary for vaccination. We want people to come and be vaccinated and be healthy with us.
And we do not check citizenship, no money, no problem. We try to operate a safe facility. I cannot control what ICE is doing.
Okay, there was a question in here about whether or not these slides would be available to share with health aides and administrators. Yes, the PDF of the slides displayed during this meeting will be available, as well as a YouTube link for the recording of this meeting. We will also include a parent flyer, front and back Spanish and English, for what parents need to know, just in case you want to have some literature available for those parent interactions.
While we pause and wait for questions. Michael, can I share the screen real quick?
You sure can. Yes, please.
Oh. State Health Department, this is the vaccine rate for Pima County. And I will drop this link in the chat bar as soon as I'm done showing this to you. But what it shows is that when kids enter kindergarten here in Pima County, 93.5% have had 2 doses, and that's really, really good. And by the time they reach 6th grade, we're up to about 97%. Now, hooray, herd immunity. That is a beautiful number. Thank you to our school nurses. But remember, herd immunity is not perfect. What herd immunity really means is that we'll have spotty fires. We'll have occasional fires in the middle of an outbreak, but we won't have a forest fire. And that's this other thing I wanted to show here. Assuming this is still projecting. This is the actual live page. You can see, you can click around and point to the counties. Michael, is it changing? And you can see Pima County here, 6th grade.
Yes.
Cochise County, 96.4. Santa Cruz doing very well at 98, and that's great. Thank you, school nurses. But if you come up here to Mojave County, that number suddenly goes down to 88%. So give a little love and empathy to your colleagues up in the northwest corner of our state. It's no surprise that when measles got a hold north of the Grand Canyon, we had that big outbreak. We're also seeing this in South Carolina. So please continue to do all you can to advocate. We have some other information for you about how to work with vaccine hesitant parents. That is indeed an art, communicating with them. But on our side, we want you to know that we don't want fiscal barriers. If money is an issue, no, we want to make certain that these vaccines get into arms. So we're glad to help teach you some of the stuff about how to communicate with people if you want, but keep doing the great job that you're doing.
Great. All right. I'm going to go back to questions. So Iris Escuela asked, oh, I'm so sorry. No, this one is from Nicole. It was Anissa. You mentioned something about 42 versus 21 days in the beginning. Missed that. Can you please repeat? Anissa responded in the chat saying, yes, 21 days is the max incubation period for measles. When we have an outbreak, epidemiology team here at PCHD conducts enhanced surveillance for 2 incubation periods, which equals 42 days just to be safe. So we're going above and beyond for our community here. We did have
Michael, can I clarify that?
Yes.
It's understood that the health department considers an outbreak over 42 days after the last exposure of the last confirmed case. But for individual children, their window of incubation is 21 days. So it's not that we would exclude children from school if they were a exposed contact who was unimmunized. We would not be keeping them out of school for 42 days. It would be really that one incubation period. But as a health department dealing with an outbreak, we consider 2 incubation periods as the window through which we are doing enhanced surveillance. So I just wanted to make that distinction.
Thank you so much. And John Netherland is a deputy director here at PCHD. Thank you for adding that, John.
Thanks.
All right, I can see next question is from Monica Ibarra. I have had adult staff members ask how severe the side effects are from an MMR booster. Laura, or Dr. Saul, I'm wondering, one of you probably will take this question.
I'm happy to take that. Side effects are usually minimal to non-existent for most people. The vast majority of side effects will be possibly soreness, redness at the injection site. Some people may have, the next day might feel a little tired, things like that, but that even is very rare. It is a widely given vaccine that is very well tolerated by the vast majority of people.
Thank you so much. Next question we have is from Eunice Altamirano. Please go over signs and symptoms to look for. Teachers are sending students when they see spots or rash on kids, and sometimes it's hard to identify. And I can see you've just shared your screen, Anissa. You're always prepared. Thank you.
Or I'll swing this one. So
sorry,
measles.
that's you, Dr. Saul.
Hey, Anissa's cool. She's smarter than
Anissa
me.
is cool.
I know. Measles is usually not subtle. You're going to have 3 or 4 days of stuff that looks, this kid is sick. And usually what you're going to see is a fever and what we call the 3 C's. And the 3 C's are a little bit medical, but it's cough, everyone knows, coryza, which is a plain old runny nose, and conjunctivitis or pink eye. So when you see fever and a rash, that should be a red alert. But some of these kids will come to school with a fever and you're wondering, why did the parent drop them off? Yeah, those kids. But when you start seeing fever with cough, runny nose, and pink eye, they shouldn't be in school anyhow with a fever. But then comes the rash. And the photo on the screen here is indeed the rash. It usually is not subtle. There's this rare thing people talk about called Koplik spots. I've been chasing measles for 30 years. I have yet to see one. That doesn't mean I want to see one. But there are kind of white spots in the mouth. It's not thrush. It's over there on the side. And usually a kid's 8, 9, 10 years old. And of course, the rash goes this way. And you can think about this Bad Bunny singing and you're dancing. Basically, it starts on the face, it goes down to the chest, and then out to the arms. So top, central, out. So that's usually the progression. Top to the abdomen, and then out to the arms. And there are just some great photos there. And of course, it can pop out on the palms. You can see there's some bloodshot eyes here. So again, remember, measles is not subtle. But yeah, it can be really severe too. And why we care is that despite best of healthcare, we still have kids dying. Humbling reminder that, 3 kids died in Texas of this vaccine preventable disease. But in case you were wondering, remember that influenza, plain old flu, has killed over 53 children in the United States this flu season alone. So again, vaccine preventable diseases, no reason for that kid to get sick and die. It's a horrible thing, but please do all you can to support it. Our real problem with measles is the kids get really, really sick. And in Texas, we saw that 12% needed to be hospitalized. They get really, really bad dehydration, nausea, and vomiting. And the other thing to remember, when you've got a parent who says, well, I want my child to have the wild type infection. I want the natural infection. I'm like, no, you don't. You don't want natural immunity against rabies. That's a very bad idea. But with measles, we are seeing 5 to 10% of the kids having permanent, lifelong damage to vision, hearing, and neurological deficits. So this is one you don't want to get, and you don't want the natural of this. So I hopefully answered your question. Back to our host.
Thank you so much, Dr. Saul, aka not Anissa. Anissa's still cool. I saw the A in your name, and that's what my brain said it was Anissa. We have another question from Iris Escueda. So we have children enrolled ages 6 weeks to 5 years old. What precautions should staff make? Clinical
And
or
I will
epi?
humbly defer to Anissa.
So precautions that I would say that staff would be making is ensuring, again, your MMR status of the children that are eligible for immunization. So the 1 to 5 year olds, ensuring your MMR status of those TA and teacher staff. I know that may or may not be a requirement of your school districts. That might be an opportunity to look at those policies and maybe review those and at least be aware, right? Whether that is policy or not. Just be aware of those. And then for the smaller, more fragile students, or your infants that you're taking care of in your preschools, work really closely with our ECE team, which is our early child care consultant team. If your schools are part of the Quality First program, to be in close contact with them. They provide a lot of guidance in terms of not only infection control and health care when we have outbreaks going on in different communications across the board in terms of not just measles, but any kind of outbreaks, but to make sure that we're taking all the right precautions and that their siblings are being excluded, that we have that open communication if there is some type of exposure, that we know. Usually when we have students in those small age groups, they tend to be sectioned off. From what I know, when we work outbreaks, we have like an infant classroom or 1-year-old classroom, and they tend to be separated. I would try to maintain those. It gets a lot easier when we're working cases, whether it's something like measles or pertussis or meningitis, God forbid. We've had those experiences, unfortunately. So I think the less mixing is actually better. So just be mindful of those infection control policies. And I would say work really closely with your healthcare directors and your administrators, and try to get a policy in place. And Dr. Saul and Laura, I don't know if you have any other guidance on that, but that's what I would recommend from an infection control side.
Yeah, and if you work with very young children, remember, theoretically, we don't give measles before age of 12 months. But following an exposure, we will step in there for a child older than 6 months. Because if you give the vaccine, then you can stop the infection before it takes root. You've got 72 hours to get that vaccine in the arm of a person who's been exposed. So those little kids ages 6 to 12 months, we will go and immunize them following an exposure. Please don't tell your parents to go, or don't tell your families to go get immunized ahead of that. We don't want to preemptively jump the gun in the absence of widespread circulation in the community. And then for children newborn through 6 months, if there were an exposure, we use immune globulin. We'd be in touch with the family and coordinate that. That is a shot we can give them at one of our clinics. If you're a little older exposed and can't get the vaccine, such as if you are a pregnant adult and unimmunized, we also give you the immune globulin, but we have to do that in a hospital or an ER because it's a great big infusion, more than we can give you in a shot. But realistically, the best prevention, of course, is make certain that as many kids as possible have had 2 doses of the vaccine. And following an exposure, do everything you can to increase circulation of the air, and of course, everything Anissa said. One final thing before someone asks, I've got a kid who's 2 years old and they've only had 1 dose. What do I tell them? Normally the second dose comes at age 4 before kindergarten. Everyone to go do that, but if a parent asks, the answer is yes. You can get that second dose as long as it's more than 28 days after dose 1. You can get that second dose at age 2, 3, or even 4. It will count for your 2-dose entry into, I think, 5th grade or wherever they do the checkpoint. But there's really, the reason we wait till age 4 to give the second dose is for convenience and adherence. That's when we do that whole wave of vaccines right before kids enter kindergarten. Back to you, Michael.
Thank you so much. Lots of good information being shared today. I am not seeing any other questions. Are there other questions from the group? All right. Well, seeing none, if any pop up while I'm closing out here, we'll take the question. So just to follow up, everyone who attended this meeting or received the invite will receive a follow-up summary email. That will include the PDF slide deck. Now, I want to share, Dr. Saul and I have been chatting in the background. We will be adding those signs and symptoms into the slide deck that Dr. Saul shared here today. So they'll be combined in. That means that the recording will not have them, but you will have them in the PDF. So just be aware of that. We will also share that what parents need to know, infographic flyer, front and back, English and Spanish, should you want to print those out to share with your parent communities. We will also share documents that were sent out very recently to school administrators and health staff. Many of you, if not all, received that email from Pima County Health Department notifying you of the cases in Pima County and with recommendations. It also included a parent template for universal communication. So just to be very clear, that is different from what Anissa mentioned earlier, which would be a parent exposure letter, right? We're providing as many resources as possible for you to be able to communicate with your key stakeholders. And as Dr. Saul said, we are very early in the stages here, and with your support and communities in your schools, your work is so critical to this mission of stopping the spread of measles in Pima County. With that, Anissa, Dr. Saul, Laura, do y'all have any closing remarks?
I would just say thank you for your time. And if you have any questions, you can always call Epidemiology. Thank you.
Same. Thank you for attending. I put my email address in the chat. So if anybody has any vaccine related questions, please don't hesitate to reach out directly to me. I'd be happy to assist you. Thank you so much and have a wonderful day.
Yeah. Thank you to all of our nurses. You help keep our kids safe.
All right. And on behalf of Youth and School Communities Program and Pima County Health Department overall, thank you for attending today. We will maintain continual communication with you as things evolve. And thank you for working with us as a team. We hope that all of you have a great rest of your Friday and a long, restful weekend. Thank you.